Back to Einstein's Eyes. Great to have everyone here. I'm your co-host, Carl Rosen. I'm an oculoplastic surgeon, neuro-ophthalmologist, Anchorage, Alaska at Ophthalmic Associates. I'm with my co-host, friend, former co-resident at Albert Einstein, Jon Ditkoff. Jon?
Hey, y'all. Hi, I'm Jon. I'm a general ophthalmologist specializing in cornea. I've been in northern New Jersey for about 30 years. I originally met Carl when we both trained at Albert Einstein, hence Einstein's Eyes. And I actually know Lee, who our guest today, very well, who's worked in my office, and we're in the same group practice, Eye Centers of America. So I'm very excited to have him back here. He's also a fan, Carl. You know, he subscribs and he likes our videos very much.
I applaud.
We're not going to talk about his favorite video. We're not going to.
I applaud you. I applaud you, Lee.
It's a very short one. You know, it was a little prematurely short.
Yeah,
you know?
no.
Exactly.
You have my total appreciation. So we're going to dive into a condition that affects millions of folks. And it flies under the radar. It's called epiretinal membranes. And these can occur after floaters or posterior vitreous detachments. But I don't want to steal Lee's thunder. Lee, Dr. Angioletti is a retina specialist that requires a fellowship. It's a particular type, a subspecialty of ophthalmology, like Jon and I have. And it's designed to work in, we call the posterior segment or the retina. Let's dive right into it, Lee. Let's talk about it.
Yeah, sure. Well, first, I've been practicing for over 30 years. I went to New York Eye and Ear. I did a fellowship at a private practice, a very big private practice affiliated with Emory. And then I did join a family practice, my uncle, my brother, my sister too. And now that was in New York and New Jersey. And then I just moved to New Jersey. So I've been with the facility. I am now at Eye Centers of America for about, 2016, I guess it would be about now. So we have a big practice affiliated with Jon, have an excellent relationship. CVDs are typically associated with epiretinal membranes, right? We see patients getting flashes and floaters. Of course, we want to make sure, again, reviewing last time, that they don't have a torn retina or retinal detachments, and also make sure they don't have other causes for floaters, such as bleeding in the eye or inflammation. But most of the time, it's the collagen fibers that are collapsing, and they're going from a very viscous material into a liquefied material. But over time, some patients, this material, I use a description of my patients. It's almost like snow falling to the ground, and you get those cells, or the snowflakes, they kind of fall. Except these cells, these glial cells, actually they attract each other, and they form like a saran wrap like material. So you can see through it, but it has the ability to stick to the retina and contract. And it's the contraction that causes the retina to be deformed, disrupted. The photoreceptors become disrupted, and not everybody, but patients become symptomatic. Be anywhere from visual loss, slight blurry vision, distortion, metamorphopsia, which is distortion, that's a medical term, and also something called image disparity, where patient may see an image smaller, even though it's clear, it might be smaller or bigger compared to their other eye, which might be the normal eye. So again, I give the analogy like a watching a movie on a wrinkled sheet. Right, the movie's fine, the projection's fine. Those are the lights that's coming into your eye. But once they hit the retina, which is like that wrinkled sheet, the image to your brain is distorted. And lots of times patients have a hard time combining the two images. And you'd be surprised how many patients are operating with 20/20 vision, because they just cannot get the two eyes to function together, and sometimes they'll have monocular diplopia, which is very unusual. Usually we think diplopia, someone's having a stroke or what have you, or a palsy, but you have to check patient, do they have monocular diplopia, right? Because diplopia could be an emergency. Like
you guys out there, that's double vision. That's double vision for you guys.
Right. So diplopia, usually it takes two eyes to see double. When you have monocular, that means that one eye sees it, and that may indicate that it's an epiretinal membrane. Now, Lee, I just wanted for the audience, how often would you say PVDs occur in folks?
I'd say the majority happen between 40 and 60. That's where the majority happen. Everybody pretty much is going to get a PVD if you live long enough. Okay.
Right. And they're floaters.
But I would say
just for our audience.
But they're special floaters.
Well, they're not necessarily. A PVD is different from floaters, because floaters I've seen patients with no PVDs or partial, and that's called vitreous synuresis. That's where there's like liquefaction inside the vitreous itself, And then what happens, the vitreous becomes hollow and there's no support in the center. It's like taking out the center part of the vitreous. And then what happens, the peripheral part, the stuff that's the outer shell, so to say, has nothing in between, or I should say liquefied vitreous in between that doesn't support the outer part. So all of a sudden the outer part collapses on itself. And that will cause more floaters because of the condensation of the vitreous on the optic nerve. We call that a Weiss ring. I'm sure you guys heard of a Weiss ring. And a Weiss ring is condensed vitreous on top of the optic nerve. And the optic nerve is very close to the macula, which is the center part of the eye. That's the part that we see to read, recognize faces, and color. So when that vitreous separates from that optic nerve, the optic nerve is a blind spot. So once that vitreous comes off, that dense vitreous comes off the optic nerve, and now it's shifting towards the macula, it's in your visual axis. That's the point between, outside, right through the pupil, dead straight to the back of the eye. Once that floater goes past that visual axis, it's casting a shadow onto your macula.
Okay.
And that's a vitreous separation. Yeah. So just for nomenclature, because some patients may hear different things. And I have we don't stage these per se, but I'm just going to use some terminology only because some lay people may hear certain things and not really know, may hear something different and not know that the same thing. But the cellophane maculopathy, which is, to me, is like only a glistening of the membrane on the surface of the retina. You could hardly tell it's there unless you do something like an OCT, a sheen, just a slight sheen coming off the retina. Then the epiretinal membrane is typically like a little more pulling. And we also call preretinal fibrosis, which to me is synonymous with an epiretinal membrane. Then you actually have macular pucker, which this is actually to me more of a macular pucker. Again, no classification. This is just me noticing that you have a very white, dense membrane that's pointing and says epiretinal membrane. That's the white fibrous tissue that's contracted. And where it says distorted retina, what they're talking about, if you can see these striations that are going across the center part, these lines that you're seeing, those are striations, and all those are being, just imagine trying to be pulling something in the white area is pulling up. It's going to cause, just like if you pulled a sheet in the corner of a bed and you pull it up tight enough, the other corners are going to feel it, right? So here, even though it's temporal to the macula, it's to the side, that white tissue, the distorted macula in the center is involved. Yeah, so the surgery is done in a typical surgical center. It doesn't have to be done in a hospital. It's similar to like cataracts in terms of the anesthesia used. You get something in your veins. block around the eye, so the eye doesn't move so much. And we make 3 tiny punctures, okay, almost like doing laparoscopic surgery they do for, like, bowel surgery. We just make little punctures in the eyes, and they're very small. And we have 3 instruments that typically enter. One is an infusion. One is a device that sucks out those floaters in the vitreous. And then we have our other hand, we have, such as this, is a forceps. And the forceps here is grabbing that epiretinal membrane, macular pucker, cellophane maculopathy, and removing it from the retina. There's other instruments that are used. There's scrapers. We also use certain dyes to identify it, because this membrane, you showed a pretty obvious one that was white, but these things are not easy to see during surgery. They're very difficult to see. I mean, they really could be invisible. Like I said, like a saran wrap, like material, you just see glistening. So one of the things we do is that before the surgery, we want to see where might be the best area to grab. It's usually around a blood vessel, but that's why before the surgery, we like to take these type of photographs so that we could dissect the photograph and come up with an attack plan. Where's the best area to grab the membrane and remove it from the back of the eye? After that's done, we check the side of the retina, make sure we didn't miss any tears, because many of these epiretinal membranes are due to a retinal tear, and in fact, 7% of people die with retinal tears, asymptomatic. They did cadaver studies. And, it could have been a tear. You just missed it during the exam, but, we do look for patients under the microscope and could really push on them hard because they're under anesthesia. And we have an excellent 3D system in our practice. It's called the heads up. Not every office has this. It gives unbelievable view. And we could see if there's any tears in the periphery to prevent a postoperative retinal detachment, which is one of the risk factors involved. We fill up the eye with some air bubble, and some doctors don't. And sometimes we don't have to stitch up the eye. And usually the recoveries from the surgery itself is about a week. But it could take anywhere from about 6 months to a year, really, to have the effect of the surgery to take its effect and to see actually flattening and less distortion. But 70–90% of patients have less distortion and improved vision after the surgery. But it's not a quick fix. The patient comes in with their own lens, meaning they never had cataract surgery. We do tell them there's a high risk of needing cataract surgery after our surgery. We usually tell them about 60% of patients will need cataract surgery within the first year, within 1 year of their surgery. If the patient's younger, that's not the case. But like between those 40 and 60-year-old patients, and obviously a little older than that, they have a higher risk of getting cataracts, which is a side effect. It's not a complication. I mean, the other potential complications we tell our patients is infection, which is like 1 in 2,000. Retinal detachment, extremely rare. I don't know. I don't even know the incidence of that. It's so low. And infection's pretty low. And then bleeding. And, bleeding is a very low risk factor too. But most of the things we take care of during the surgery. If we see a torn retina, we take care of it. The retina did detach during the surgery, we typically take care of it. Bleeding, same thing. We cauterize, we locate it. Obviously, infection is delayed. Anywhere between 2 to 5 days is typical if an infection presents itself. And most of those patients are treated in the office with antibiotics we shoot into the eye. So, right. But otherwise, it's a very successful surgery. A lot better than it was back in the 90s when we were using higher gauge and we're taking down the conjunctiva. Sometimes the eye doesn't look like you operate on it. It could be so clean. Not painful.
Right. The prognosis and takeaways are really good for the patient.
Yeah.
You can get significant improvement. There may be some distortion though, however, so people should know about that. Yeah. And I think also it's important that early detection and individualized decision-making is part of the process.
Yeah, I'm going to bring up a couple of things. One is just to reiterate symptoms. So some people, as we all know, have epiretinal membranes and have zero symptoms. In fact, I'm amazed how many people I notice it do a special test called the macular CT and the person's completely asymptomatic. And then there's a significant number of people that do have a little bit of the distortion, like Lee was talking about, where they're a little bit minimally distorted in the center, what we call metamorphopsia. But I think most of those people end up not doing surgery. That's as a general ophthalmologist, because I see a lot of those people who end up not even always going to the retina doctor. And then, of course, you're seeing the people that are more symptomatic. Do you follow many of these people without surgery? Like what percentage of people that you are consulting on?
Yeah, I would say the incidence, it's probably about 15% of patients go on to need surgery. I would
Okay,
say
yeah,
15 to
yeah,
20%. Maybe it might be a little higher now because of the type of equipment we have. But it used to be 15%, is probably close to 20%. So I say usually about 1 in 5 cases that present to me end up needing surgery. But when we
right,
first present with them, obviously we want to make sure of a couple of things, because we're talking about idiopathic. It's typically related to PVD. Idiopathic um, epiretinal membranes, right? There's other causes for epiretinal membranes that have to be screened for:
right,
inflammation,
yeah,
trauma, and also vein occlusions. Sometimes patients have vein occlusions. They didn't know they had a vein occlusion, and occasionally we'll do an angiogram, and you'd be surprised. It doesn't happen
mhm,
often. Be surprised that the patient actually had an angiogram. You actually see it as capillary non-perfusion. That's a whole other thing, because now you're talking about having a patient work up for, why did you have a vein occlusion?
right.
Especially a young patient, healthy. Why do they have a vein occlusion? So, and the same thing like uveitis.
And you're
Common's
bringing
going
up
to be
all the
obvious.
good reasons why I send these people to retina specialists. Because I'm not going to pick up a lot of those things other than the
Right.
membrane.
We have the equipment to do the angiogram if we think
Yeah,
it's necessary.
yeah,
But what's interesting too, and throughout the years, I'd be surprised how many times I'll see a patient initially, and then depending on the epiretinal membrane, I'll see them 3 months later. And there have been several cases where I'm shocked how quickly the membrane
yeah,
formed in 3 months. And sometimes the patient's not aware of it, because they're
yeah,
not going on like this. And the thing is that, and you both had said you want to get it early, because because people say, well, what's your cutoff for vision? It's about 2050 to 2060. I mean, everybody's different, but why 2050, 2060? Right? That's vision impaired.
yeah,
So we tell patients there's approximately about a 70-90% chance we're going to get your vision 2 lines better. So what's the legal driving vision, right? It's typically like 2040, I think 2050 with
right.
during
2050.
the day in New York, 2040, I think in the metropolitan area. So if the patients are starting out 2050, 2060, and you get that 70 to 90% improvement, they're back to driving vision, right? So, and I tell them, the longer you wait, you come in next time, you're 2100, we can still operate, but we're not looking at, necessarily very good vision.
Right.
So, I don't want to put a gun to the patient's head, but I'm saying you really have to, be, especially when they're 2050, 2060. And again, I've seen patients with 2070. They don't want 2080. They don't want to have surgery. They're doing fine. I think I just had someone in your office, John. Actually, she just was so ecstatic with the vision. Her left eye, she's had cataract surgery, and the right eye is significant. She's 2100 epiretinal membrane, but she's had it for years.
Yeah.
So that's also going to change the prognosis too. I mean, she's had it for years, and just from that chronic traction, she probably has some underlying, probably some permanent changes that, I don't know if I could promise her 70 to 90%. It should
Right.
be better than it is now, but she's like, I'm good. So, it's amazing how some of these membranes are so thick, schisis that's pulling the retina up, and the patients are 2030 and they're perfectly happy.
Yeah.
So you can't always go by the OCT. It's really the patient. It's a patient complaining of their symptoms, just like cataracts, right? I mean, John, you see cataracts, like,
Oh
wow, it's
yeah,
a significant.
absolutely.
I'm good.
We
I'm
call it
good.
20,
That's
we call it 20 happy.
Yeah.
20 happy.
So in
Never heard of that one.
neuro-ophthalmology, you'll see a patient and you'll think that they want, their vision is lousy in one eye, and you want to do something for them. What if you dig deep and you look back, or if you glean it through the history, you find that they're suppressing, or they're a mild amblyope, and they've always been they have a dominant eye, and the dominant eye just works fine.
Sometimes, yeah. But
Right.
I think people also go into denial and they cope, they adapt. But something else I wanted to bring up. So when you do the surgery, we know about face down position, which I'd like you to explain that. And then when you have a patient in front of you, you tell them about the postoperative care for the first few days, whatever you tell them. And then what do you usually tell them about when they could expect to see improvement? Because I think a lot of times the vision drops for a while and then it starts to
Yeah,
improve. What do you tell them?
Yeah, no, excellent question, John. Okay, first of all, you mentioned face down position. There's no indication for face down positioning. That's typically macular holes.
Okay,
Okay.
sorry.
So yeah, that's actually happens in our own practice, because we literally give them a booklet that tells the patient about macular holes, epiretinal membranes, retinal detachments. So you will know how many times, and I have to tell my staff, like, please don't tell this patient to get a chair or a pillow, but they have to take it down, okay? Because there's no reason this patient needs to be face down. That's to include holes and tears, right?
Okay.
Macular holes especially. But epiretinal membranes, you just need to relieve the traction. That's it.
Okay.
Okay. So that's number one. So yeah, as far as the vision, first of all, if there's a air bubble, we don't put gas typically. Air bubbles, I like to put in for two reasons. First of all, when you put an air bubble, your eyes fill with air. There pretty much is a good chance there is no more floaters in the eyes. Because these patients are going to go through surgery. A lot of them complain of floaters. They're so, oh, you're going to take out my floater? I'm like, yes. I'm like, oh, thank goodness, you know. And these patients just want me to remove floaters who don't have any epiretinal membrane. So the ones that have epiretinal membrane, they have both, right? They have the distortion, decreased vision, and they have the floater. So they're very happy to hear that. So I just do this routinely. I like to fill the eye with air for two reasons. Number one, make sure I got their floaters out, because floaters cannot get inside an air bubble. The air bubble pushes out all the liquid through my little cannula that sucks the fluid out, and the eyes fill with air at the end. The other reason why I like to do it is because I typically don't like to use stitches unless they're absolutely necessary at the end of the case. These are trocars, they're small, we pull them out. If the eye's holding pressure, I don't put in stitches, because the stitches we use could be very annoying. I mean, it could be the most annoying part of the surgery, especially vicral sutures as opposed to gut. There's different ones we use depending on what the surgeon's choice is. And they could take like 5 to 6 weeks to dissolve, and they really annoy the heck out of the patients. They get these they touch their eye where the stitches are. There's usually 3, really annoying. But the surface tension of the air bubble goes against the sclerotomies. Those are the punctures, and it prevents egress of the fluid inside the eye. So the air bubble for me is there not for face down, not to flatten out the retina, but more to make sure floaters are out, and also to close the sclerotomies. Okay. As far as the vision, you're right. We don't, and I tell these patients, we don't bother scanning them for at least a month, because you're right. There's trauma. I mean, this is trauma. It seems like, oh, it's such a when you're pulling on some of these membranes are so adherent. It's shocking. And this is why a lot of these patients, they don't have big changes thickening on OCT, but when you're in there and you're pulling on these membranes and you're seeing the retina being lifted off, you just see how adherent these membranes are. So even though the anatomy might not look, again, that bad, they're causing quite a bit of traction. So that's going to cause more edema post-operatively. So if anything, and I've done some patients before, we actually, because they insist on doing it, a week or two later, because usually the air bubble's there, so it's hard to see after a week, but usually the air bubble goes away after a week. I've had patients come in sooner, and we actually demonstrate that there was actually more swelling before the surgery from the edema, from the trauma. So about, I would say, 4 to 6 weeks, patients start noticing improvement. But
Yeah.
you know, you still have your patients that have, this is Northeast, so a lot of patients have a lot of expectations of here, unfortunately,
Yeah,
and they expect it to be fast. You know, especially when they have had a cataract. Oh, the next day it looked great. This is retina tissue. Retina tissue is not the same. It takes a while for it to improve. And I demonstrate a lot. I like to educate my patients with the OCT. We have a big monitor in our office, and I'll put up the before and after, and I'll show them, you know, their improvement. They'll see it going down, but of course they're still like, but I still have distortion, and of course the area that's still thick is dead center in their macula, despite the fact that all the parts around their macula have basically normalized in terms of thickening. But again, most of those patients over time improve. It's just not a quick fix. The other thing also is that some of these patients we had mentioned are phakic, and we're going to speed up their cataracts. So when you operate, you know, so I typically don't like patients operating before 3 months because I want flattening the retina. I like to get 2 OCTs in a row that show stability. Otherwise, these patients can become, I get over myopic. I think if they measure, they do their IOL master where the retina is too thick, they actually go over minus and become a little bit more myopic than they would have. So we like to see at least I do. I like to see 2 stable OCTs, and I'll send them back to the cataract surgeon to have the cataract surgery out.
Well, great job, Lee. Thank you so much. I think our audience will enjoy that.
I learned a lot.
Yeah, I learned a lot too.
I've been doing this 30
So-
years. I'm learning.
Like, subscribe, and once again, Lee, thanks a million. We'll see you guys on the next one.